Good afternoon. My name is Dr. Monica Yelhair. I'm a research assistant at the University of Arizona Cancer Center, and I also work with the Oliver's Research Program for the Native American Outreach and Engagement. My name is Ashley Johnson, and I'm here listening from Reach Lake Vanderbilt Ojibwe from the State Department here for Travel Development.
Oh, to that table.
Hi, I'm Chris Henning, and I work at the National Institutes of Health.
Dave Wilson, Director of Tribal Health Research Office at NIH.
Hi, I'm Gwen Evans-Goliaska. I'm Sophie, and I'm a researcher at the Policy Research Center at NCAI. Good afternoon. Good afternoon. I'm Dr. Yvette Rubido. I'm the director of the Policy Research Center at the National Congress of American Indians. And thank you all for being here.
Hello, my name is Vanessa Crushy, member of National Nation, but I do representing the California Rural Indian Health Board.
Good afternoon, my name is Steve Packer, and I am the research scientist for the National Missing and Unidentified Persons System.
Christine Crawford, I'm with the National Institute of Justice and the Department of Justice.
Hey, T, I'm Louis Miller, Self-Governance and Trancodic Tribe.
Good afternoon, Travis Lane, Assistant Director, Intertribal Council of Arizona.
Gloria Simeon, Oglala Community Traditional Native Council, Bethel, Alaska.
Hi, I'm Abigail Echohawk, Assistant of the Pawnee Nation of Oklahoma, the Director of the Urban Indian Health Institute, and Chief Research Officer of the Seattle Indian Health Board. I'm also a member of the Tribal Advisory Group for the All of Us Precision Medicine Initiative.
Good afternoon, my name is Tim Seward. I'm with Bob Strauss-Stephen Law.
Okay, and again, I want to invite anybody to the table. You can see your space over here at the table. I'm not sure if you think you're going to be required to speak to the table. That's up to you entirely. So I have a couple of reminders. We're going to say this several times throughout the session. There is an evaluation form. I forgot to ask you to fill this out in an early session. So if you still have your packet, and there's several of you that are here that were here this morning, if you could maybe fill that out at the beginning of this session from this morning, but also we have one for this afternoon. So please fill out your evaluation form. Again, for the people who are on the web, there's a section on the web page for you to be able to send in your questions or comments. And then also we will take comments emailed to us at kking@mn-e.com. So please let us know what you think is occurring to you. And so I do want to remind you that this session is closed to the press, but our session is also being recorded, so we have the benefit of others that want to be able to view it, not view it, but to hear it at a later time. And it will be posted on the NIH website and accessible by tribal members to help inform during the consultation process. So the consultation process, if you didn't know, originates from an executive order that a couple of presidents ago signed, and other presidents continued under executive memo, presidential memo, and has not been revoked. Hopefully it won't be. And so the consultation process requires the federal government to, in a government-to-government relationship with tribes, to reach out to tribes and gain their input on different policy issues that affect us. And so I'm very happy to report as a member of the NIH Tribal Consultation Advisory that we have articulated a process for how that's done through NIH. And obviously it's a work in progress. It can always be improved, and we will continue to give that input. But the consultation process that we'll follow today under HHS Tribal Consultation Policy has presented the protocol and has been defined to ensure that the highest-ranking official from respective tribes is given the opportunity to address the session first, followed by other elected officials. And then when you do speak, if you can just acknowledge who you are, your tribe. And again, because we don't have a really large audience, I don't think we're going to be limiting anybody today, but we do go through the tribal leaders first and then work our way through. Our earlier session, we used that practice, and everybody who wanted to speak got it on. Is that, you know, I have just, my genes are, I have some predispositions to certain health conditions. I have family members. Generally, we don't live past 60 years of age. Heart disease and diabetes. I'm vegan. I've been vegan for 10 years to try to fight off high cholesterol and blood pressure. I have high blood pressure and high cholesterol if I don't take care of it and focus on it. And I also run my butt off. I run about 50 miles a week, even at this stage in my life, to try to ward off those chronic health conditions. And so, rather than run hard or work out hard, I want to work out smart. I want to figure out what specifically it is that I have to do based on my human genome, and what are the environmental factors or conditions that might predict whichever path, and most importantly, my life expectancy. And so this really, I believe, has a lot of promise for Indian country to affect some of the chronic diseases. I will say right off the bat, because it might be an elephant in the room, is that sometimes, and I said this morning, you know, even though our advisory committee has advised NIH, sometimes something gets lost in the translation, so we have to say it repeatedly and over again. But I do believe that they are genuine in wanting to understand our needs in Indian country, to incorporate our input. So the consultation is very important so that they hear from us. And that doesn't mean it's perfect. By no means am I giving a broad endorsement. And I understand that the research did start before us and started some level of data collection, but based on our input, they are incorporating that, and they're taking a step back, and they're revisiting and revising how they're going to approach. And this consultation is an example of that. This is the first step in us being able to give from Indian country very clearly our position on how we feel it's appropriate to do data collection.
Our tribal citizens. And so I hope that our input is rich and full and in a positive sense. So if you see something that you didn't like on how it's been implemented, or if you've got concerns on how research has been done before, please express it. But also please be mindful of this is our opportunity to shape how we want it to happen. We try to do it in a way that can give us recommendations, and NIH recommendations for how it should happen going forward. And so with that, I would like to hand it over to Dr. Tabak. Just a little anecdote. Dr. Tabak represents NIH on the HHS Secretary Travel Advisory, for which I serve, and has been for a number of years, so that's how we became friends. And I remember, and I told the story this morning, is that Indian country knows some of the reasons why we have some of the worst outcomes, statistically, right? And we had been hammering tribal leaders across the country to explain this to HHS. And I actually saw that light bulb come on when Dr. Tabak fully appreciated and understood that and articulated it back to us. And as a result, NIH has prioritized research related to historical trauma. And so I really appreciate that. And so that, to me, is an example that if they listen and they invite us and we express it, there's a chance that it might be incorporated. So I really do value your input. Hopefully we get really good, rich information. With that, Dr. David.
Well,
I'm going to go over there so I can see your presentation.
okay. Well, Chairperson Hammond, I want to thank you so very much for both your overview, which is actually better than my presentation. So keep his overview in mind. But I do appreciate the privilege of being able to address all of you today. I want to begin just with a definition, which I think many of you already appreciate, but as a starting point, to describe what precision medicine is. The simplest way to describe precision medicine is for you to look at me for 2 seconds, as sad as that sounds. This is precision medicine in its earliest, crudest form. If I gave you these glasses, you wouldn't see very well with them because they are designed for my very, very poor eyesight. It's an example of precision medicine. Now, we can do a lot better than that, but this is a starting point. And so, as the slide indicates, this is an approach that is emerging which takes into account basically 3 things. Lifestyle, so a vegan lifestyle, 50 miles a week, that's impressive, okay? Your genes, and we don't have much choice about those, we're born with those, and then your environment. And that intersection is really, really important. And so what we want to be able to do is we want to be able to understand that intersection and then tailor approaches either for prevention and or intervention, taking into account those unique attributes that each one of you bring to the table, so to speak. Now, the All of Us Research Program is really unprecedented. We are seeking to engage over 1 million volunteers. These individuals will be our research partners in the truest sense. And importantly, this group of individuals, this group of research partners, will reflect the broad diversity of the United States. Most biomedical research studies are conducted on people who look just like me. This is what biomedical research typically does. And obviously, I don't reflect the diversity of this nation. And what works for me may not work for one of you. And it may not work because of those 3 different elements that I spoke to a few moments ago: genes, environment, and lifestyle. And so each one of us brings something different. And that's why we need to understand that in a relationship. Our research partners will provide data on an ongoing basis. This is voluntary, of course. And the data will inform a variety of research studies. This launch began in May of 2018, and so far about 245,000 people have started the process, and a bit over 150,000 individuals have completed all steps of the initial protocol. Now, very importantly, over half of these individuals are members of racial and ethnic minorities. This group of participants, our research partners, is going to be unlike any other group ever assembled in this country. Now, again, we're doing this to accelerate health research and medical breakthroughs, to enable individualized prevention, which is really, really important, but also treatment for all of us. That's the gist of what we're trying to do. So, the goal is to oversample, to purposely enroll as many members of historically underrepresented groups in biomedical research to ensure that any benefits that are derived, in fact, benefit all groups, including people who live in rural communities, individuals from sexual and gender minority communities, individuals from racial and ethnic minorities, and individuals from tribal communities. At present, we are only enrolling individuals who are over the age of 18, although in the future, children will be enrolled. We are not able to take anybody who is currently incarcerated, but importantly, you are not excluded because of any pre-existing health issue. As many of you know, for most scientific studies, they look for a very narrow window of individuals. They either have to be very, very healthy or they have to have only one disease. Well, that's not the way most people are. They have a whole range of issues that they deal with. And because we want this to be representative of the entire nation, there's no precondition that eliminates you from this study. Now, very importantly, American Indian and Alaska Natives are not being actively recruited to this study. All of us partners are currently prohibited from active recruitment of American Indian and Alaska Natives. However, we have had individuals who have signed up on their own and then have, after the fact, self-identified as being American Indian or Alaskan Native. So we are not turning anybody away who chooses to sign up, but we are not actively recruiting. Please.
Just so that we don't misinterpret what he said, is we have very strongly advocated that that active recruitment not happen with tribal communities until consultation happens. And so we're not purposely excluding them for any other reason other than the respecting our request to do consultation first. The other thing that we were advised in the previous conversation was that the use of the data will be compartmentalized for any data that has been collected up until now from individual American Indians. And so the whole concept of individual Indian versus citizens of respective tribes, and those as our citizens and our jurisdiction over our citizens was something that took a little bit for us to get to understand, but I think we understand that now. But any data that has been collected will be segmented, and we'll probably somewhere down the road talk about how that might be or may not be incorporated in the final research.
Thank you very much for those clarifications. And so, again, building on what the chairperson has said, there is, in fact, a data browser that's available to the public, but it has no ability to analyze any of the data by race, ethnicity, tribal affiliation, or zip code. This was in great part due to the recommendations that the Tribal Advisory Committee at NIH gave to us. And so even though this browser is available, we have these delimiters on it because of respect for the discussions that we've had with TAC. So what are we going to ask our research partners to do? It's summarized in this slide. Well, obviously, they start by raising their hand and enrolling. To do this, they have to have an informed consent. And as part of this, they will authorize access to their electronic health record. They are then provided with online a series of surveys. And then, if they choose to, they can have a series of physical measurements taken. And if they choose to, they can provide biospecimens, blood, typically saliva, urine. And they can also allow us access to wearable and digital apps. Now, my 47-year-old watch doesn't count, but some of you probably, well, it was It's my engagement gift for my wife. So, but some of you, have these app things, and access to that, of course, has very valuable information. Now, very importantly, the bottom line on the slide, participants can choose to complete some or all of the available activities. Some participants have already chosen to answer surveys, but have decided they don't want to provide measurements and biosamples. That's perfectly fine. Some information is better than no information. Now, data access is very, very important, and is something that we have discussed, and no doubt will continue to discuss. So let me just review quickly the principles that we're following. We want to provide broad access, but in a very safe, controlled manner. Now, why do we want broad access? Because we want as much scientific brain power looking at challenges and questions as possible. But we'll use a so-called data passport model, meaning that access to data will be granted by tiers, by different levels of requirement and need. The data use will be audited, and it will be reported publicly. Everything will be open and transparent. The data will be stored and used in a secure enclave. Importantly, the data cannot be downloaded. It can only be used within our secure enclave in the cloud. So all the compute will be done in the cloud with tools. It can't be downloaded and put on your own personal server, and so forth. A very important feature of this, and something that we've given much thought to but still need additional input, please, is the potential for stigmatizing research. We feel that transparency on data uses will go a long way in preventing this, but we also will require regular assessment. Consortium researchers will have no special or early access to the full data set. Now again, the bottom line on this slide, I'm often asked, who owns the data? The oversight of data access is owned, if you will, by two groups in our governance model: the Committee on Access, Privacy, and Security, and the Research Access Board. And there will be members of American Indian and Alaskan Native communities on the Research Access Board. So voices from your communities will absolutely be heard with regard to the oversight of data access. Yes, please.
So you've heard me say this before, but I'm going to formally say it in the consultation, is I know of one other area that collects data across different racial, ethnic, and it's a national data set, and it's the National Center for Education Statistics. And so to gain access to that, when I was at dissertation level, writing my dissertation, I didn't have direct access to it. So basically there are super users that are trained and certified for access. So my dissertation quantitative person on my dissertation committee was one of those persons. And so the way that I gained access to the data set is she had to log in, and then she trained me on what I could and could not do. And the data set didn't allow you to do anything you can't do anyway. And then, and like you said, it couldn't be downloaded, it couldn't be exported. And being one of those super users, she was trained on ethics and the use of data in racial ethnic populations. One of the main reasons for this is because there was an earlier stage when reporters were getting to it, and they were coming to spurious conclusions based on limited level of knowledge of what they were even looking at. And so I don't know if there's been any thought about that, but certainly people who have access to the data set, broader access to the data set, should have some level of training and certification in the appropriate use of it and with the ethics.
No, thank you. And in fact, that leads very well into the next description, which is still in draft because we're still working through this, we envision 3 separate types of users. So it's somewhat similar to what you described. There will be public users who will have access to data that has minimal risks to anybody because it's just aggregate. There are no identifiers. This is the sort of thing that anybody, should be able to access. Then we'll have people who are registered users. So this is the intermediate level. So done because these data have some risks of identifying, and they will need a formal account to be able to access the data, and that access will be logged and may be audited. But then the most highly sensitive data, that can only be accessed in a controlled way, sort of like your super users, if you will. And they must receive direct approval from the Research Access Board to access the controlled data. So the most potentially sensitive information, that will be under strict control by the Research Access Board, and certainly the experience that you had with the so-called super users who were trained specifically in ethics, obviously that makes a lot of sense. And again, this is all draft and things of that nature can be incorporated.
I would recommend, so in my dissertation phase, and I think this might be true for other dissertation students, but in our program, we had to become CITI research certified. And so I would recommend, if there's any chance of risk of identifying research participants or even categories of participants, that at the registered level they should have to have the some certification.
Formal, right. Okay, thank you. Now, let's just talk about the timing of data release. First, to reiterate what's available now at this moment through the so-called public data browser, which is a beta version. It only provides summary statistics about the data set. It does not include any information about American Indian or Alaskan Natives whatsoever. Again, with a thanks to the NIH Tribal Advisory Committee for that input. Future versions will likely include some sorting by race, ethnicity, and sexual and gender minorities, but still there will be no American Indian or Alaskan Natives as a separate category. We will have to work through the specifics of that, but during this period, there will be no specific point to American Indian or Alaskan Natives. Now, sometime in the winter, 2019, 2020, we'll release the first version of the All of Us data set and the first set of researcher tools. It will include survey, measurement, and electronic health data. At that time, we will begin to generate genomic data, that is, data related to your genes, the composition of your genes. But to date, we have no genotype or sequence data from anybody. So that hasn't started yet for anybody in this study. Projecting 2021 and beyond, we envision that there will be additional data types, including lab test data and linkages perhaps to external data sets. Again, these are just guidelines. The bottom line here on the slide, all release dates are dependent on security and usability testing. We won't go to the next step until we're absolutely confident on the security issues and, of course, on the usability. So now I'd just like to briefly summarize for you the consultation process that we've been engaging in and what we hope will be next steps. We did form a tribal collaboration working group to provide input on how best to collaborate with American Indian and Alaskan Native communities. We have planned a series of tribal consultation sessions in several of the IHS regions during this summer. This is the second consultation that I've personally participated in, and one listening session. So I've been seeing a lot of the country the last few weeks. These consultations will be supplemented by additional listening sessions. And if any of you have recommendations for ones that we may not yet have on our radar, please do let us know. We'll review all of the input that we obtain. We will make changes as appropriate that apply to tribal participants and their data. And importantly, and this is the other place that we would really value your input, how can we best create tribal partnership opportunities here? How can we work with your communities so that this work maximizes advantage to members of your nations? So, per the consultation process, there was a Dear Tribal Leader letter and a framing letter that had been sent out. There was a Federal Register notice. Process was informed by this report of the Tribal Collaboration Working Group. Versions of this are available electronically at the website that is listed here. We have been in Sacramento. We're here today, obviously. We have on the books to go to Spokane, to Washington, and Denver. We've also had the listening sessions that are listed here, with more to be had. And then, as Chairperson Payman alluded to, there was a webinar, and that was captured electronically, and you can access it on that link. And I believe there are also summaries. A summary sheet, do we have those here, of the webinar in case anybody doesn't want to listen to the whole webinar? We have a short summary of that. The TCWG report overview is very comprehensive, and I won't go through this in any detail other than to hit the high points, all of which I'm sure are self-evident to you. First, of course, is that we need to attend to and respect tribal sovereignty, and we need to acknowledge the American Indian and Alaskan Native experience with the government. We need to include tribal representatives in all of us governance areas, and we are doing that throughout the different areas listed there. We appreciate that we have to handle biospecimens properly. We have to train researchers on cultural sensitivities and support research questions that are important to tribal nations. Again, your input on which questions those are would be most valued. We have to continue to remain responsive. We can't just come here and consult and say, great, now we're done. This is going to be a continuous process. We understand that this is a marathon, to use the running metaphor, not a sprint, and we are in this for the long game here. We intend to hire one or more dedicated tribal liaisons, and we will continue to ask communities whether or not there's, what scientific questions do you want to see addressed using these resources. And we also want to let tribal nations know what the program has done as a result of the consultation process. So again, the bottom line on this slide, all of us could be of potential benefit to tribal nations and individuals, and could become a model for positive, bi-directional partnerships on research between the NIH and tribal nations. That's what we're aiming for. That's what the goal is. And I think if we all continue to work together, we will be able to accomplish that. So these are just some questions that have occurred to us based upon feedback that we've received. and I'm just listing them here. I'm sure you have many more, and we welcome them. We, obviously, the program recognizes that there are many unique considerations that we need to engage in when partnering with tribal nations, and we would be very interested in knowing what you feel are best practices for these types of initiatives. The TCWG report outlined many points. There may be some you support, there may be some that you disagree with. Knowing that would be valuable, whether you agree or disagree. All of that input would be very, very useful. This has already been alluded to by the chairperson. How do you recommend we handle the issue of tribal affiliation? What do we do with individuals that have enrolled independently and who self-identify? What are the major research questions that are of most interest to your nation or community? How can we help advance research conducted by members of tribal nations? If we don't engage tribal nations to do some of this research, then we're not reaching our full potential here. And this should be a wonderful opportunity that we need to make happen. How should the program collaborate with tribal nations, clinics, and organizations to enable American Indian and Alaska Native participation in this program? Are there initial pilot partnerships that we should consider as taking a step in that direction? Now, we've heard over the past several weeks from both listening sessions and formal consultations some things. I'd just like to quickly summarize what we've already heard. Obviously, please amplify, agree, disagree, and add to this list. Under the general heading of cultural respect, understanding, and trust, clearly there is great importance of acknowledging past harm and trauma from previous so-called research. Differing beliefs and viewpoints from different tribes will certainly influence their participation in research. We've heard loud and clear that the tribal epidemiology centers would be critical partners for all of us, and indeed several individuals who are affiliated with those epidemiology centers are on our tribal advisory committee. The Native American research centers can also be powerful partners for engagement strategies. We need to accommodate individuals who may have limited computer access, and the issue of English proficiency in some communities must also be taken into account. And we need to stop talking like geeks, and we have to be use more lay language, everyday language, and I'm guilty of that for sure. Again, just continuing with some of the feedback that we've heard in terms of the science, and there is some overlap, obviously, but we're trying to capture everything. The importance of including tribally guided research in this program. Again, if we don't do that, we haven't reached our full potential. The recognition of traditional medicine as a form of precision medicine. The importance of helping American Indian and Alaska Native communities with a full understanding of what genomic research is and how it can potentially link back data to American Indian and Alaska Native communities. There needs to be clarity around funding sources and publications. There needs to be clarity about the NIH All of Us single IRB. And then finally, with regard to data and biological samples, we have had conversations with the Indian Health Service regarding RPMS, the Electronic Health Record Access. This is critical for success. We appreciate and understand that proper handling of biospecimens from American Indian and Alaska Natives is different than for other groups, and that each tribal nation may have a slightly different view of how this should be done. So that's a conversation that needs to be had. And then, of course, it goes without saying that protection of data, security, and privacy are absolutely critical. So with that, I hope that gives you a reasonable overview of the program. And obviously, we welcome comments, questions, etc.
So what I'd like to do is to kickstart with a couple of comments. I think it's on. Yeah. And I did this morning, so you've already heard this, but I'm really, really excited about what the research can represent. And I want to use one quick example in tribal communities of how sensitive this is and how the rollout, how very careful this needs to be. Is in my community several years ago, we were approached, it was through a CDC grant, and we were approached to do a data match with the cancer registry of our population. So we're the largest tribe east of the Mississippi. We have 30,000 members in Michigan alone. And so what they asked us to do was to take the cancer registry data set and do a data match with our tribal membership. Well, obviously, all the hackles went up and all the fear and all the concern went up at our council level for that. We don't have an IRB, so it had to go directly to our council. And so what the request was very specifically is to use like access to do a unique identifier, which would be your first name, your last name, between the two data sets. And then all it would do would spit out like a next generation list that would be zip code and whether or not there had been incidences of cancer for that tribal member. At no point did it have your name or anything like that. That information, it took us 2 years for my council to finally agree to do it because they were so concerned. But the benefit of that is now we can do a data sort for our tribal members that have cancer and what zip codes. That's critical information. If there's issues of environmental racism that might explain why there was higher rates of cancer in certain districts, that's how you get to that data. And you don't otherwise have that data. You don't have that information. You could maybe say, well, I have it in my IHS or tribal health clinic. I have access to that data, but unless all your tribal members come to your clinic, you don't have that data. And so figuring out ways to get at data and the value of that data is very important. This morning I used the example that I grew up in a community that didn't have indoor plumbing, and so I have H. pylori. We didn't get indoor plumbing until I was 15. And so H. pylori is a condition in your intestinal tract or your esophagus, like that, your GI, your lower GI, where basically you can't metabolize iron. And so my iron levels are very, very low sometimes unless I get a treatment. That can be life-threatening. At some levels it can be very, very low. So anyway, I got treated, I got diagnosed, I got treated, and it's like about a 3-year treatment sort of thing. And then the other day I posted it on my Facebook post, and a bunch of my people that I grew up with said, hey, I have that too. And how else would we know that? How else would we have that information if it weren't for some kind of way of getting at that data? These different genetic research or genetic sources of information like 23andMe and Ancestry.com, they may be able to give you some level of information that might tell you, certain health conditions that certain populations might have, but that's very generic data. This is going to give us specific data to your respective communities. And once you understand the marriage of those three factors, and it's environmental, it's genetic, and it's, what was the third one? Lifestyle. Once you understand those three, then you're going to be able to better understand and do better public health for your respective tribal communities. So that's why I'm really excited about it. And it's not that I have a bias and I'm going to look away from any concerns that I have, because I still have those concerns, but they're willing to listen to what we have to say. And so with that, I'm going to open it up for tribal leaders, chairpersons first, tribal councils, so we'll go ahead and take your input. So raise your hand. You had your hand raised, ma'am. Remember, you got to keep your hand on. Or you can use the handheld mic, which is somewhere over there.
This thing was on. Okay, I just wanted to say a couple things. Corey Simeon, Ohutsahumia Traditional Native Council, Bethel, Alaska. This may be a level up, but it goes back to that primer conference that I attended in San Diego. The first red flag was that there's secondary and tertiary uses of biospecimens that have been provided that the owner of those specimens may not necessarily have been made aware, or the print was too small to read. So in this conference, there was a lot of talk about biopiracy, big data, and recently on the news, I guess tying ends together to me was the capacity of artificial intelligence right now. Artificial intelligence, what was the other? Tech companies have professionals that are mining information about us all the time. Every time you touch a key on your computer, it's being entered somewhere, these algorithms of who you are and what you do and how you do it. I get really afraid. Like, for example, today, I said, okay, this time I'm not going to sign up for the Players Club and just kind of go with cash and see, because there's a lot of casinos that have my algorithms right now. Because I like to see what kind of benefits I'm going to get from the Players Club. So that's, to me, that's a very dangerous thing. That already, I can order something on Amazon and my next few ads on Facebook show the thing that I'm ordering on Amazon. So those kinds of algorithms and that kind of information that's already being collected about me every time I touch my phone. Alexis is listening to me all the time. It's scary. It's scary when I start thinking about medicine, my personal health, my DNA, my native blood that still has secrets yet to behold. Who's going to have that information maybe even before I do? So I think that those are cautions that we need to really, really take into consideration. I mean, there's nothing governing artificial intelligence right now. Who's the boss of artificial intelligence? So we need to think deeper about these kinds of things. They scare me. They really scare me, because this kind of stuff can be used against us in so many different ways. And we've been victimized already because of who we are and how we have survived. So think really hard. Thank you.
Thank you. Did you have your hand up, or are you helping us?
I'm helping.
Okay. Other questions or comments? Maybe we should ask if there's firewalls to limit access.
So your concerns are spot on, really, because we are in an interconnected world. There is no question about that. And it's because of that very reason we have created a data enclave which is cordoned off, which is kept separate and cannot be penetrated due to the security efforts that we are engaged in, so that the Googles and the Amazons and the other groups that you refer to will not have access. These data will never be shared with pharma. These data will only be available to groups that go through those 3 different tiers of data access. Now, in terms of the algorithms, the artificial intelligence that you spoke to, so happens that I sit on a committee within the United States government that's looking at how we should be thinking through the ramifications of artificial intelligence, because it's real. But here's, I'm going to turn it around a little bit. So one of the biggest shortcomings of using artificial intelligence for medical diagnostics is the data sets that are being used to train the algorithms are biased. So there's this great algorithm that was developed for cars that are self-driving. And the algorithm was developed basically using white populations only. And the bloody cars don't see any people of color. They had to shut the program down because it was trained in with a biased data set. So if you look at it from that perspective, through participation, controlled participation, safe participation, secure participation, you enable the data sets to not be biased, but to be reflective of the nation as a whole, so that whatever tools are come up with do in fact encompass what the nation looks like, and not just one group of people only. The secrets of your genetic background that you refer to, you're absolutely right. I am sure that there are secrets there that could be of benefit both to yourself and your community and beyond. This type of program, we feel, can help unlock those secrets. But the only way to do it is through a partnership. Otherwise, it's an exploitation, which is exactly what we're trying to avoid. So your comments are very, very, very important. Thank you.
Other questions or input? This is your chance.
So I have a comment.
Yes, please. You have to state your name.
My name is Sherry Ely Mendes. I'm with the Pyramid Lake Paiute Tribe, and I'm a tribal council person. I think with any type of research project, I think it's really important. I've learned over time that it's really important to use a community-based participatory research approach, so that the community is aware of what the goals of the research are and then are able to either participate or not participate. I have some of the same concerns as this beautiful lady here has, and I guess you're right, historical trauma has made us very leery of any type of research. And although I feel as if the research is necessary to kind of combat some of the health disparities that Native American folks are enduring now, I also have a apprehension to pinpointing those disparities and where they come from, and the genetics of a people who already have to prove themselves as being Native American. I can't just say I'm Native American anymore. I have to have a blood quantum, and I have to have an affiliation with a federally recognized to be recognized as Native American. So when you take the information and you find the secrets of a generation of people, then the stated use of that is, we would all either agree or disagree with that, but the future use of that information is very critical because we won't be here forever. And the next guy that comes along that decides that information is important for defunding health care for Native Americans, because there's just not enough evidence that there's a difference in my blood than anybody else in the room or anybody else in the country. So I think that there's a danger in that respect, because the use of the information is going to pass through the government, who basically funds our health care and holds our land base, and basically, for lack of a better term, controls our sovereign nations. And so I have a concern about it. I'm curious. I think I think it's important that individualized medication or medicine happens for people, because I can say that when we look at a group and use medication formulas that don't match everybody, you can kill a whole group of people, and it could have been totally prevented. And I'm living proof of that, and I feel as if, why wasn't I educated on that? Why didn't I hear that this medicine versus that medicine can make me healthy again? And, you know, when you're on the brink of those kind of life-changing moments, then, you know, then you feel the need to know more. But the mass gathering of that data and how it's used in the future is probably my biggest concern. And yeah, they do track you. And every other casino will know if you have fun. I know.
As a researcher, one of the very complicated issues in any research with American Indians is the question of who is American Indian. That's a very straightforward question, but there's not an easy answer. And I'm hoping the consultation process ferrets out some of that, because you have enrolled tribal citizens. Some tribal organizations, some tribes have blood quantum requirements, some tribes don't. You have intertribal blood, tribes that I'm intertribal. I'm descended from 3 different tribal groups. I also have non-Indian blood, and so how does that factor in? You know, which genetics are dominant? And so also you have the issue of tribes that have citizens that are, I say, dislocated, but we're talking generations, that have moved to other communities, like urban areas, that are often completely ignored by their respective tribal organizations. They're just left out there to fend for themselves. And so, you know, one thing that we haven't figured out yet, well, we've got the sensitivity and the appreciation of how to work through this, is how do we collectively know whether they are a tribal citizen or self-reported? You know, for some reason, and I'm not going to use any politician names, so I won't make any jokes, but for some reason, some people have this warm, fuzzy feeling about Indians, and some people claim to be Indian, right? But I don't know really what the benefit of that is. It wasn't beneficial for me growing up. There's not like affirmative action funds waiting, or, you know, any of that for other racial ethnic groups really doesn't exist in American Indians. So, but you know, the whole idea of American Indians being close to nature, and there's kind of dances with wolves was really popular because people are infatuated with American Indians, right? I mean, I'll say it like it is. And so you do have a lot of people who will claim to be Indian that could check that box, and then your data is going to be, it's going to be horribly misoperationalized. It won't be correct. It will be spurious results based on it. The issue of blood quantum or descendancy is also very complicated. So is somebody who is several generations removed from census and not enrolled, not an Indian? If their genetics say that they are they to be excluded? You know, and I hear your concern, and I'm not judging it at all, about repositories that have our information. I'm old enough to remember the red list, hearing about my mom talk about the red list, and people were put on the red list. How many remember what a red list is? The list of American Indians that were on the watch list, kind of like the communist list. And so any data collection that has that a warehouse someplace represents a threat. You know, it's only as good as the ethics of the people who are in government and adhering to the government at that respective period of time. But the potential benefit, you know, we had all these concerns, and we came forward with these concerns, and the job study, and we were pushing for them in advocating that they oversample, because the way the data was being collected was just too simplistic, and it was small n problem was inevitably going to result, and the people who were operationalizing the study didn't realize that American Indians are not homogeneous, that we're not one population, but we're a nation of nations, right? And unfortunately, the administration interpreted that as they didn't want to include it in the study. We wanted to include it properly. What happened was they dropped it. We were dropped from the study. So we have to figure out how to give our concerns so that they address our concerns, but seeing the utility of the results potentially on the other. Dr.
I'm sorry to interrupt. I just want to provide clarification for the audience to make sure everybody is able to give input. So I just want to make sure I'm clear. So people are being recruited now. They're being recruited at big medical centers. They're being potentially recruited at like CVS's or Walgreens and that kind of stuff. They're randomly recruited around the country in different areas with partners that are happening there. You don't have anybody recruiting on tribal lands right now, but you hope to, hopefully, if that might work out. But still, American Indians' last names are being recruited right now, just not purposefully, but just incidentally if they walk up to this place. And then once they get recruited, they sign a consent form that's essentially broad consent, that not only are they saying you can take my blood and my survey data and all that, but people will be able to use that if lots of researchers and the public could use all that depending on the level of protection in the future. So the person walking in to this medical center who agrees, signs broad consent, potentially hundreds or thousands of researchers could use that data at some point, as long as they got it reviewed by your board and all of that. But currently, there's not anybody who's tribal on those boards. And even though you're saying the public information and the non-identifiable data set won't have like names or ages or anything, you know, genetic material is identifiable, and in ways that might be geographic or in ways that might be ancestral groupings or whatever, so it's still kind of identifiable. So one of the issues that I think I've heard from tribes is once that person gives their blood, gives their survey information, and then
But no, you laid it down in a very comprehensive way. Thank you. And I do hope you get additional feedback.
Yes, sir.
Richard Grayman with San Juan Southern Ute Tribe. I've been hearing a lot of this consultation that on my behalf, what I think and how I think with this so-called research. Just a couple of months ago, I went to USCA, and that's United States Conference on AIDS. I went over there. I've been there for a whole week. National Indian Health Board, sponsored me to go out there. And it was just surprising to see all the statistics and the percentages, Anglo, white, African American, Hispanic and Latinos, and then what about the Native Americans, Alaskan Natives? Where did they go? Where's the percentages? And the question for me to ask you is, what are the benefits going to be again for us? As a tribal leader, for me, I'm very disappointed not to even see that at a national level. And to be in the midst of 3,000 to 4,000 people, non-native, we were only about 65, and I was only councilman at that conference. And I'm just like, you're saying there research, we're gonna do this research again. And then just a couple of weeks ago with Youth Tribal Leaders meeting again, there was a hospital up in Salt Lake or some area wanting to do some kind of cancer research as well. And the same thing goes again with them. Are we just guinea pigs for other national people or national, I would say other Americans? Are they just using Native Americans as guinea pigs? That's the way I think about it. Are they trying to, just like what the elderly was saying, we need to be careful with what we do and how we go about this. And that's the reason why I try to say, you know, let's go back into and look into and ask our elderly of what to do and how to go about this. And what my question would be is, how are these researchers going to be helping us? Because I haven't, like for 2 years right now, I've just been hearing consultation, research that, research this, but I haven't seen the progression of it, progress of this whole process. So for me, I would, on a positive note, I would say I would like to see this, but in a positive way, rather than having our elderly say, oh, they're just putting us out. Just like the elderly said, you never know what comes up in the future. When you're ordering something, you already know that your name's going to pop up somewhere. That's the way I look at it now as well. So that's why I'm saying, you know, if you guys are going to do research, you know, help us out.
That's somebody on the phone.
Help tribal nations out, rather than just helping yourself out. Help the tribal nations, help the elderly, help the youth groups, and emphasizing what you're trying to do, what you want to do. Maybe our youth I'm very into our youth wanting to go into the health field or the different fields. You know, help them as well. Not only just yourself, help the tribal nations. That's all I need and all I want if you guys want consultation. And then going back into this consultation letter, I would recommend not a dear tribal leader. To me, I've set aside so many dear tribal leaders. There's going to be, with our tribe, there's 7 of us in our tribe. 7 tribal leaders. President, vice president, 5 tribal councilors. So our thought is tribal leaders, any one of us can be tribal leaders. So if it's a dear Councilman Grayman, then I would open it. Oh, this is very important then. But if it says dear tribal council leader, I'll just put it off to the side. So I would strongly recommend you to, put the name in there rather than a dear tribal leader. For me, from my perspective, that's how I look at it. Just now, I just got a dear tribal councilman Grayman letter from one of the national recreation areas, and I would open it up and read it. I did. I had to respond to it right ASAP right now. See, that's one of the things that, for me, my perspective, I would recommend that. So, something for you guys to think about as well. All of these different tribes, they have their websites. They have their chairwomen, their chairmen, their tribal council, their names, addresses, you name it, they're on there. Once you log on, they have their names on there. That's all I ask of you right now. Thank you.
Other, input? Short question. There's one that came in here that I don't understand, and I don't mean it to sound partisan. I'll just do the question. But what about the Trump administration trying to lift the ban on gene patenting?
That's somebody on the phone, though.
How do you say that? Patenting. And I don't even know what that is, so.
Yeah, so there's, so right now, there's a Supreme Court rule that you can't patent gene sequence.
I'm trying to figure out where it's coming from. Because, I mean, I'm hearing it fine. So it could be this one person that's talking into it. I'm sorry, the person that's on the phone.
So I do understand. We had a session this morning that explained it, and,
hearing what's coming off the phone system.
And so basically, what's not eligible for patent is something that is naturally occurring. If there's something unique about it, or some methodology, or some product as a result of it, that potentially could be patented. But otherwise, it's kind of like the public domain. So we don't actually spend. With regard to sending a Dear John letter to the tribe, well, my name's not John. So there's no warehouse of that information anywhere. And I know that NCAI tries to keep a list that is immediately updated, because tribal elections happen all the time, people turn over all the time. The BIA has a list that is horribly outdated as well. So I know what you're saying, because we get inundated, and we fought for a consultation. We get consulted now, and I tell you the truth, I can't keep up on all the times I get a consultation request. But understanding that, some more affirmative recruitment of trying to get that information from respective tribes is something that we have to figure out how to do.
If I may, just comment on some of the elements that you brought up. So first of all, there's no disrespect by sending a generic Dear. It's not a good excuse, but it's just a practicality. But there really is no disrespect. I think you said very clearly why research programs conducted thus far have fallen way short.
The reason this program is seeking to, the term used is oversample, as diverse a group as possible, is so that we are inclusive of all peoples in the nation. The reason that we want not only to know what specific questions tribal communities want studied, but also to include tribal members who are actually doing the research is for the very reasons that you articulate. So my bias is going to show now. I want to get every young kid excited about science. I don't care where they're from. I don't care where they live. I want to get them excited about science, because I can think of nothing more exciting, okay? A really good way of doing that is having research conducted by people just like them in their communities. That's how you get them excited about it, and that's the sort of, if you will, entree into other things. That's the type of thing that we hope to be able to enable here. But you're right. I mean, the track record's not so great, and we have to acknowledge that, and we've got to do something about it. And the only way we can do something about it is with your help, with the collective help of the group. So, but thank you for your comments.
Okay, over here, then over here, and then here. Starting. Synapses are firing.
Hi, Travis Lane with Intertribal Council of Arizona. I have a question. So, with this All of Us project, is the research restricted only to precision medicine research projects?
We are using that as a sort of tagline, if you will, as a summary statement of the types of things that we're doing, because we feel that by learning what contributes both to health and resiliency against disease, as well as the disease itself, that will lead to precision intervention.
So somebody could just look at my blood and not necessarily my lifestyle or environment.
I would be, they could in theory, although I think with big data, which was mentioned earlier, I suspect that most investigations will try and look at all of the parameters at the same time. But yes, it's possible.
Okay. So what might be helpful, because I'm not a health researcher or anything, but I've never seen any sort of peer-reviewed articles about the benefits of precision medicine, how it's helped communities, what that looks like, how they use that how they even use lifestyle, environment, and genetics to improve someone's health and treatment. I've never seen an article like that. That might be helpful to share on your websites and things like that.
Okay. No, certainly we can do that because there are examples of that. I give you personal examples, but yes, there are examples.
All right. Yes, ma'am. Don't forget to say who you are.
Okay. Hi, I'm Gwen Evans-Lamiespa. I'm with the NCAI Policy Research Center. And my question is similar to this. So I'm reading a sample of the consent. And I know that in broad consent things, you need to have kind of the scope of work of all research that falls under it. And from what I'm seeing on this, I don't know what the scope of research is, so I don't know the breadth of research that falls under this. All it says is lots of studies. So I'm hoping you can elaborate a little more on this.
Okay, so I need a little help. What exactly, do you want to know the types of studies that will?
Yeah, I'd like to know, so I know that, you have the single IRB, and that has to review all of the research proposals moving forward with the secondary research. And I don't know what kind of studies necessarily fall under this, for what will be reviewed or accepted by the single IRB for this. So can you kind of elaborate on what the scope of work is that any kind of research will fall under?
So again, much of it we don't know yet because researchers will need to propose the questions that they want to answer. What is being created here is a platform upon which research studies can be enabled. There are no specific here's study 1, here's study 2, here's study 3 yet articulated. What we're creating is a resource platform. So unlike many of the other studies that I'm sure you're very familiar with, where you've got a very detailed protocol and everything is laid out in advance, we're not there yet. We are just building an infrastructure so that you have a cohort of individuals who are pre-consented for basic things. Specific studies may require additional consent. When I'm looking at you, I'm guessing. Yeah, go ahead. Yeah, please. That's why I'm pointing to you. Which part of that did you get?
You have to keep your hand on it.
Okay. So just to clarify, the single IRB that we use is for what we do with the research resource itself. So someone who has funding to do research, for example, at their university, their IRB will review that study. It's not the IRB that we have that is really just about the platform that Dr. Tabak described. So I did want to clarify that. The Resource Access Board that Dr. Tabak described is the board that is responsible for defining some of the parameters around the, what we expect will be thousands of studies that will use this very big data set. So it's a little bit of a different process. Again, we're not the study. We're the foundation upon which folks will come in and conduct the research.
Yeah, I was asking more. Can you kind of talk about what those parameters are?
So again, that's hard to describe because we anticipate that you may have social scientists that come in to use the research resource, epidemiologists, basic scientists, people all in between. So we really hope and believe that the research resource will, will provide a foundation of data for very broad kinds of research. So we can't really define kind of point by point what studies will be done in it. Again, because of the diverse data that we're collecting, we expect that people from many different disciplines of science, again, hard science, soft science, will all be able to find a home in the database from which they can conduct great research to advance health.
Of course, she didn't mean soft science. My kid's a social psychologist, so I have to defend him. In other words, unlike the traditional study that, you and others are familiar with, where you enroll a cohort, you do the study, the cohort disbands, and then when you do the next study, you start all over again. What this is doing is it's creating this very large, very diverse cohort, which will remain in perpetuity, so that as researchers come up with great ideas of particular studies, they can access not necessarily everybody in the study, but subsets of people in the study, in order to perform the research question that they're interested in. So it's a little different than the typical, frankly, NIH-funded, study that you're.
So maybe what we're asking for, is, for our population to have some safeguards on the use of data that would perpetuate, that would continue into the future, and how that data could be used. And so I have to say it. So during one of our STAC meetings, Dr. Collins was very excited to roll this out to us, and being somebody who's watched different research that has exploited American Indians, I raised my hand and I said, so how will we protect against somebody, concluding that Indians are genetically inferior, or just there's no hope, or, just let them die, sort of thing. And he was really shocked by that question. And, some people, I guess, are too brilliant for their own good. And maybe he's never thought of that question before. He's never had to. He's not from the same demographic that I am. And so maybe this input can incorporate our concerns across Indian country that any kind of data, future use of the data that's articulated, protect, and carry our concerns with it, so that the results of that can't oversimplify and really, in a way, stereotype American Indians. So that's a very real concern. Yeah, please.
I think this question's a really critical one for tribes, and so now I'm not even clear on the consent process, because so people have to have a consent process when they sign up at the health center or Walgreens or whatever. That consent has to be broad consent. And broad consent under the common rule requires that you have a clear scope of work of how that data is going to be used. And so that's the question that Gwen was asking. But now, when Gwen says, that once the data is in the database and a researcher applies to use it, you're now saying all their IRBs at their universities are going to be involved, which all of a sudden exponentially increases the risk for the tribes, because we can't trust the IRBs at many universities in the country. And so do I have a wrong understanding of this, or because if it was just all of us had a single IRB that was reviewing and making sure that the researchers were doing good research, that'd be one thing. But if you're also invoking all the university IRBs, the IHS IRB, and everything, then you're going to have to invoke the tribal IRBs somewhere in that process to ensure that, and universities don't always talk to the tribes. And so I'm suddenly, and we've written a brief on this, I've studied it, and now I don't even know what the process is. So can you guys explain? Because it's really critical for tribes to understand the stages of where tribes can ensure they are protecting their citizens. And if there's multiple IRBs involved, then that's more concerning, I think. So I don't know. Help me.
Thank you. Well, that's part of why we're here, right, is to get great advice on how to proceed. So the Resource Access Board that we've established, and which thankfully as of, this week has a really wonderful AIAN representative on it. We're super happy. We are ready to start work on that. Is going to be defining the policies and the trainings that among the things that we can control are the policies about the kinds of research that we're putting out there that are allowable within the database. The consequences of not following those policies, again, they're policies. I mean, people can be bad actors, but, we have to live in hope that people are good actors most of the time. So the Resource Access Board is going to be defining those for the study and is going to be responsible for keeping an eye on the research. We require, this is one of the requirements, even though we don't have a lot of the policies fully baked right now, one that we do have baked is the requirement that researchers, when they want to propose a study, they have to publicly post what that study is using the database. So it's not only us, the NIH and the All of Us Research Program and our Resource Access Board that can monitor the work that's being done, but anyone else can as well. So, yeah.
The Resource Access Board is not an IRB. It's not a single IRB. So then all it's doing is regulating who can access the data. So the IRB approvals are up to whatever the researcher is governed by.
That is correct.
That's interesting. So the challenge is normally if a researcher wanted to do research with a tribe and the university was involved, the university and tribal IRB approval or council approval or research review board would be required. But since this is a national data set, the university researcher comes to you and says, I want to do this research, and I also want to look at some American Indian stuff. How does the tribe get involved in this review process? That's what I'm very unclear about.
Well, that's again, just to defer, this is what we're here to try to get feedback on so that we can come up with great processes that do get tribes involved.
So are you open to suggestions? Are you open to suggestions?
We want suggestions.
When I did my dissertation research, I used a data set at a university, so I had to get an IRB approval there. I had to get IRB approval at my host institution that was giving me the degree. Well, not giving me, I earned it. So there was two levels. And so what my tribe does, because we don't have an IRB, is if a student comes in, first of all, we won't entertain it at all unless they have a university IRB approval, first of all. Then we articulate additionally on top of that, including intellectual property protections for the data that's mostly to ensure that they don't desegregate, that they don't use any identifiers where somebody could figure out what community was studied. And so I guess I would recommend, and this might be a big ask, is that any research that might categoricalize, that's not a word, research a particular population should probably include an IRB approval from that respective tribe. And if that tribe doesn't have an IRB, sometimes there's coalitions of IRBs of tribes or consent from that respective tribe. However that tribe defines that. And I know this is getting very hairy because it would be easier to just give up on the Indian population given how complicated this is going to be. Also, we have the issue of small n. And so, and I will tell you from HRAC and from NIH that tribal leaders that have worked in this area are very dissatisfied with research, national research or university research that relegates us to other. So we can't talk out of both sides of our mouths and say that we want oversampling, that we want to be included, we want to have the benefit of public health research, and but on the other hand, I don't believe we're saying that. I think what we're saying is that given our track record with the federal government, with universities, with the unethical approach of research in Indian country, research on Indians, that our concerns need to be incorporated. So wherever possible, for a respective tribal nation to have to weigh in on consent and the use of the data. But now we're talking two different things, because one is collection of data, one is the use of the data after the data is collected. And so this is very complicated, because I still think that there needs to be some level of consent from a tribal perspective, a tribal sovereignty perspective, of the data that is collected. So once we are up and rolling, assuming that's going to happen, is that the data that's collected. The other thing is verification of that, whether or not that person is even an Indian. And so I don't know how do we get to that. I think there's ways to do it. We could articulate how we can figure out how to get to that. But otherwise, you're potentially going to have a lot of people who are claiming to be. I would say the group that have volunteered already, there's probably a big percentage of those people who aren't even Indian at all. And so the only way that you can get to that is through a tribe, because there isn't I know the BIA tries to collect your membership list, and we say no to them all the time. Nope, you can have our zip codes, but you can't have our list, because that's a matter of sovereignty. So all those things have to be figured out and operationalized.
So let me try and unpack this a little bit. So we're pretty tenacious. We're not going to give up just yet. But I guess what I hope we're able to do is we're able to reach an agreement to have discussions at, by tribal nation by tribal nation. Because if we do it with one tribal nation, it's not going to be the same for another tribal nation, okay? But let's say that a particular tribal nation agrees to have an in-depth conversation with us, and we come up with an approach that is consistent with values, community norms, etc. So now people from that tribal nation can enroll, and then the reach through, now what are we going to use the data for? Does it now go, and I think that's part of the discussion. Now you've got to go back to the IRB if there is one. You indicated that your particular nation has no IRB, but you have other ways of dealing with this. And is it a little more complicated? Yes, but that's how we're going to get a data set that's representative of the whole nation, right? Because absent that, what we don't want to see happen is people just throwing their hands up and saying, too complicated, and we'll just, that's not the answer now. But we appreciate that, in other words, what we're looking for here is the general framework. And we're getting a lot of very important feedback, and frankly, we've heard some things here today that we've not heard before. I mean, so it's really been extremely valuable. We get a general framework, but then we've got to take that general framework, and I think we then have to operationalize it with those tribal nations that raise their hands and say, yes, we would be interested in having additional, in-depth conversations. And the hope is that, that many, some, ultimately can come to an agreement that is mutually appropriate, and thereby being inclusive, but also being cognizant of the need for protection, and not just now, but in the future, because that's come across loud and clear. The concern about, okay, you folks may be nice, but what about the next group, and the group after that, and the group, and that's real. I mean, I do appreciate that. But I do think that there is opportunity to work through this, and I suspect that if I'm making this up, so let's say we come up with 6 different, I'm making it up. I suspect that all 6 will have similarity, but there will also be some, some differences, some nuances. I don't think that's a bad thing. Because again, I think participation, some participation is better than no participation. So I think some of you know that NIH entered into an agreement with the Navajo Nation on data sharing for the ECHO cohort. And that, it took time, and there was a lot of discussion, and, Dr. Dave Wilson here obviously was very involved with a lot of that. But we do now have an agreement. Now, can that agreement be ported to your nation? Maybe elements of it can be. I don't know, but maybe, as a starting point. But we have an agreement, different study, not all of us, different study. And that's how I think we can approach this, because if we don't do that, then we've got this dilemma, which you said very poignantly. Where are the American Indian and where are the American Indians? I don't see them. They're not being represented. So, but you will all need to help us get there, and we can't because clearly we're not going to be able to figure this out ourselves.
So we're going to go to Abigail, then I have a housekeeping, then we'll go back to taking a question.
So thank you, everybody. My name is Abigail Echo Hawk. I am the Chief Research Officer at Seattle Indian Health Board, the Director of the Urban Indian Health Institute, and I am on the Tribal Advisory Committee for all of us. And I just want to make very clear that these comments are coming as for my organizations, not as a member of the advisory committee. And I just want to start actually by saying thank you to Dr. Dave Wilson's office. I would say in the past couple of years that it has been a complete shift in how we're working with tribal nations and ensuring good feedback, and I would encourage you to further fund his office because we need more of that. We are seeing some integral things happen, and I've worked on 28 NIH-funded studies across 14 institutes in the past years, and we're really seeing a shift in change that is coming from that office, so I want to say thank you publicly. I have some comments and kind of going to go through the slides. I took notes as you went through the slides. But first I want to start by recentering us and thinking about that we are doing and thinking about culturally rigorous research. And so I know I come from thousands of years of researchers, and in fact the Pawnee people were the first geneticists. We genetically modified our corn and to get it to the different species that we currently have today. And I think of one of my uncles, my Uncle Fred John from Itasca Lake, Alaska, and he always used to tell us a story. He would take us out to this lake, and we would count the number of beavers that were there in the spring, so we knew how many to hunt during the winter, so that the people were both fed and had food, but so that there'd be beavers again there the next spring. So we gathered data, we evaluated, we did it rigorously multiple different times for one reason only, and that was for the good and the well-being of our people, because we love them and because we care about them. And that's where culturally rigorous research is started from. And so when we have these conversations, it needs to be acknowledging that Indigenous peoples are science. And this isn't an outside, just an outside initiative. This is part of who we are, and we are reclaiming that through processes like these consultations and listening sessions, and ensuring that we are equal partners as these types of initiatives move forward. So you're presenting to a bunch of scientists who are carrying that and have carried that within their blood, which we're talking about blood, and that blood memory that comes with it, called genes or genetics or epigenetics, as those genes have shifted, but it is something that we have always been and will always be. So in thinking about that, I actually worked on a project with Dr. Spiro Manson about 3 years ago, and there is a series of videos, 2 videos with the American Association of Medical Colleges that sat down and talked with urban Indian populations very specifically about their thoughts on precision medicine. I would suggest everybody take a look at those videos, and also those at the NIH, to really see and hear multiple perspectives on where and how people are thinking about precision medicine. And as we go into the slides, you had the principles of data access up there. And I think one of the things, from my perspective in working in this for quite a while, is what's missing is unintended consequences. Not thinking about what might be stigmatizing when you start and monitoring throughout that, but what is going to happen is there are absolutely going to be unintended consequences. From the equity framework that was just presented in, are we actually going to have these discoveries ending up in our communities? Or are you going to be building medical discovery for the elite based on the backs of Indians? And so it's really looking at what are those unintended consequences and having an eye on that from the very beginning. Tribal representative on all of those boards, and I know that was one of the recommendations that came out of the advisory committee. We need that now, because one of the things that Dr. Rubidoux and her staff were talking about is what kind of studies are going through, what are the things that are happening. If we can get representatives on those now, that is integral, again, as we begin to build and understand what is going on, and they'll be able to bring that feedback back to these groups, back to their tribal leaders. And I would also suggest, when we talk about those who sit on those boards, that you use their tribal affiliations. American Indian, Alaska Native is talking about big groups. When you're talking about one person, I'm a Pawnee woman, and that's who I am. I'm not American Indian. I'm a Pawnee woman, and with that comes the stories and the responsibilities. So whenever possible, use people's tribal affiliations, just out of respect for their tribal communities. And the other thing in the principles of data access that is integral is looking at the tenets of indigenous data sovereignty. I do sit on the U.S. Indigenous Data Sovereignty Board, and we look at indigenous data sovereignty and the fact that as in a government-to-government relationship, any data that is gathered about us needs to be governed by us. It needs to be interpreted in partnership with us. And so indigenous data sovereignty is something that has to be paid attention to and becoming part of thinking about how that access is given. And then when we're talking about the data access, who are you defining as researchers? I think of my grandma Katie John from Mentasta Lake. She never graduated high school, and she was probably the best scientist I've ever met in my life. I was just telling this incredible woman that my son got stung by a bee in Alaska, and I reached over to a tree and I chewed up some leaves and I put it on my son's arm, and I didn't even think about it. I just did it. Because that's the way that I had been taught, and she had passed that knowledge down. And so when we think about researchers and we look at how the RFAs that come out, the way that NIH places those, and even as you put these good barriers in place to ensure that data is accessed appropriately, you have to think about who you're defining as a researcher, and so that it doesn't become an elitist group that's doing that, because we know that there's absolutely underrepresentation of American Indian, Alaska Native scientists and PhDs and those that are actually funded through the NIH to receive and to be the principal investigators on this project. We can't always be the research staff. We need to be the principal investigators. And so really thinking about how and that is defined as you think about who are the researchers. And also in that data access, it needs to include tribes, it needs to include tribal colleges and universities, and it needs to include tribal epidemiology centers, which I do direct one. It can't just be academic institutions. And very often when those designations do go up, that we're not included in that. I think about the Chickasaw Nation. I mean, they are completely capable of doing anything the University of Washington would want to do in terms of their IRB and the brilliance of the people that they have there and the academics that they have within their organization. So we need to ensure that when we're defining who the researchers are, that it isn't an elitist Western concept model, but it really recognizes, and I think that this is something that other communities of color are also going to be very interested in and fighting for when we think about this initiative. When you're defining American Indians and Alaska Natives and you go through to sort through the data, American Indian, Alaska Natives, and Pacific Islanders are some of the largest growing multiracial groups in the country. So it's really imperative to ensure that people are able to check individually racial categories, and that when the researchers go in to look at those racial categories, that they can disaggregate that it doesn't come up in one multiracial category. Or one of the things we see very frequently, if you were to collect both Hispanic and Latino and American Indian, that Hispanic and Latino is the only one that actually shows up, and they don't count them as American Indian or Alaska Native. And so that is one area, again, ensuring in those multiracial categories that it's able to be sorted in that way. In the slide you had on elements for creating success, you had urban Indians do not require tribal approval to recruit. The characterization of that, I wouldn't say that your element of success is the fact you don't have to get tribal approval. And so what I believe within the Tribal Advisory Committee, one of the feedback that I brought to them is my greatest fear in having worked in genetics and genomics for many years is that when they look at all of the perceived barriers and things that take a long time to go through tribes, then instead they're going to show up in my office and say, hey, can we just recruit from your clinic population? I have 45 American Indian Alaska Native people that are part of my clinic population, and they expect not to have to go through tribal approvals. And so we have to watch and be very cognizant of the fact that our urban Indian populations are not being preyed upon through this initiative, because when we look at these large research centers and where they're at, is that they are in large urban settings with these really, great universities that are gathering this information. We cannot let it become a predatory process as to where they're only recruiting from urban Indian populations to specifically avoid going through tribal approvals. And I do say specifically, I've been doing this a long time, and I have seen people do it, and we have had to push back really hard against those investigators who come on with the purpose of completely avoiding tribal approval, if at all possible. That is a way for them to try to circumvent tribal sovereignty, and it also doesn't recognize that under indigenous data sovereignty, I am an enrolled citizen of the Pawnee Nation of Oklahoma, federal trust responsibility, and the ability of my government. I have one president, his name is Bruce Pratt. I am a citizen of their nation, regardless of whether I'm on the confines of the Pawnee Reservation in Oklahoma. That still applies to me in Seattle, Washington. So you have to be careful with that in particular, and I think the wording of that slide is off, because it's not a element for success that you don't have to get the tribal approvals. It is a cautionary. You need to work with the urban Indian organizations, and for example, when we're defining who is Indian, the reason there's a lot of interest in the urban Indian programs that are funded by the Indian Health Service is that we do verify enrollment or descendancy as defined by IHS in order to capture the reimbursements that we do. And so that we do have a wealth of information, and we have these incredible people who access our services that we have a responsibility to care for, and that includes making sure that research projects are not preying upon them simply because they don't live in the confines of their reservations. The other aspect that hasn't been talked about a lot is the economic impact. And so when we think about precision medicine and just medical discovery, whether it be a new social behavioral intervention, whether it be a medical device, whether it be whatever it is, that there is money that's made out of it. This is called the research enterprise for a reason. There's a lot of funding that comes to it. A lot of funding that goes to the NIH and to others. And very rarely do we actually see those funds get back to our communities. Well, we are the most popular to include in an NIH study because people want to research about Indians. The saying is, we've been researched to death. But we have seen very little benefit of that, and particularly when we look at the economic impact of that. And so I know that's going to be a concern of our tribal leadership, is how is that economic impact actually going to reach their tribal citizens? And I mean that economic impact also in the studies that are funded. Again, we're building socioeconomic and academic prestige and economic impact. Again, when we look at where the funding goes to from the NIH, it is not to communities of color, nor is it to principal investigators of color. So how is there an effort to mentor, to bring up, I currently mentor 15 from undergraduate to postdoctoral and medical students right now. I don't get any money for that. We just do it because it's a necessary part of caring for those next generations, because I want them to be the ones who are doing that. And instead, what we see with these kinds of efforts is, again, the prestige of and what is perceived as the knowledge holders tends to be people outside of our communities. So how do we begin to engage in conversations that looks at economic impact at a multitude of levels, from the money being able to flow into the tribes by ensuring that we are both understanding that tribal colleges and universities, tribes, urban Indian organizations, and indigenous research organizations like my own tribal epidemiology centers have the ability to conduct these kinds of studies and should be part of these processes. And that's also looking at the dissemination and the implementation and how those plans are made up. I was at that same conference, the HIV conference for USCA, and the tribal leader is absolutely correct. Not a single slide, it said statistically insignificant. And my feedback to them on that is that when we are not inclusive American Indian and Alaska Native populations, that particularly within the data and the research, and if we are not doing all of the things I've talked about and what is talked about here at this table, is that, it's an active participation in the genocide of our people by eliminating us through the data. And so we have to look and think about how and why that is happening. And when we think about the small n, which is the small sample sizes, my team are experts in doing small sample size calculations. That's what we are experts in, which is why it makes us key to ensuring that when these studies are done, that organizations like tribal epidemiology centers are brought in to ensure that that doesn't happen and we're not eliminated through the data. And again, it needs to have a continuous equity lens. How is the discovery of medical devices, whatever it is, actually going to benefit the communities of color? Because historically, that hasn't happened. We just have to look at the Hep C medications. How long did that actually take to reach Indian country when all of these middle-class and upper-class white people were getting access to and had access to the hepatitis C medications before it actually reached marginalized populations, particularly American Indians and Alaska Natives? How long did that take? Those gaps are unacceptable. And so we have to be thinking about and requiring those principal investigators to be thinking about that so soon. And my elder over here, she talked about some of the secrets that our blood holds. Some of the secrets aren't meant for anybody else to know. I think about my tribe, the Kikita Hockey Band. We have songs, we have dances, we have things that are just meant for our community, and that's okay. And so it's really taking the tribe's leadership on what is appropriate for their tribal community and what may not be appropriate for others. And that is going to vary, which is why these consultations are so important, because some secrets are just meant to be a secret. And I do believe in precision medicine. I'll just finish with one story. I'm sorry I went so long. I need a lot of notes. Is that I started in this by doing, I was doing biospecimen work and was and interviewed more than 300 American Indians and Alaska Native people from more than 250 different tribes. So it was a lot of different tribes, obviously. And I met this one woman, and she did our survey, and I did the interview with her, and she started to cry. And I asked her, I said, "Oh, are you okay?" And she said, I didn't know about this. She was talking about biospecimen collection for cancer specifically. She said, and she told me, she said, my mother, and then her daughters, so a grandmother, a mother, and a granddaughter, all had breast cancer at the exact same time. And she said, if I had known, if somebody had asked me to donate a biospecimen, if I would have thought it would have helped my family or helped my tribal community, I would have given that. And so she was in she was being treated at the Fred Hutchinson Research Center Hospital in Seattle, Washington, one of the most prestigious cancer research centers in the country. There's also a perception that we don't participate, and so people don't ask us. And so I think these kinds of things, and one of the results of this All of Us initiative is going to be broader than just the collection of the biospecimens, but really thinking about the overall impact that can happen when we actively participate in research processes that have to be respectful of tribal sovereignty. If they don't start there, then they're not going to be successful. But when they do, I think of that mother, crying and telling me she would have done that. I wish she could have, and I hope that for all of our people. And what I love about precision medicine is I know I may not see some of the impacts of it in my lifetime, but my kids might, and my grandchildren might. And I sing songs for my children's children. And I think that's what precision medicine really does fit within the indigenous concepts that we have as Native people in looking forward to those next generations. And so in looking forward, we have to also appreciate what happened in the past and looking at the historical mistrust of research in order for us to move forward for the future generations.
That was an amazing primer on this overall, and I appreciate that. And it does remind me to ask the question, for consultation. So some people are really good at articulating it on the spot. Some people need a little bit more time to synthesize it and bring it together. You have people that are on the call, and there will be additional consultation sessions. And if we could go back to that slide, maybe, the dates on those consultation sessions, so we can help get the word out. But my question is, somebody here is recording everything, and all of that will be distilled into our comments. Will that be posted so we can see that, and to make sure that it's reflective of what we had to say? And then also, do we have a time period by which we can submit formalized comments that we didn't craft today and submit those?
So the short answer is yes. The synthesis will be posted, but what about the time frame?
So we would love to start, kind of getting a report together and really synthesizing feedback soon after the August 21st consultation. So we haven't put any hard deadline on it, but if we could get feedback by like August 28th, that would give us a lot of time to, we're already now starting to really kind of get a database together of feedbacks, that we've got everything organized and we're ready to go. But we would love that. We'd love to have some, like a final report by the end of September if possible.
So for the benefit of the people who are in the room and the people who are listening, they could have up until the 23rd of August to be able to submit any of their consultation comments from this consultation.
We could make it even. We could say August 30th. We could say through the end of August.
Okay, good.
That'd be
We
great.
appreciate
Thank
that.
You. And if can I give a plug for the ways to submit information? So if you go to our website, we have a cell phone where people can call or text. We have a 1-800 number where people can call in. We have an email address if people want to submit feedback by email, and we have our snail mail address. So we're trying to put out every modality. There's also a listserv people can sign up for to get additional information as we add listening sessions, for example.
All right, don't forget your evaluation. I'm not wrapping up or anything, although it might be wrapping up. But don't forget your evaluation form. That's helpful to know. I also want to call your attention to vacancies, and I'm looking over at Abigail. Vacancies on the NIH Tribal Advisory. If you can see where those vacancies are, we do have an at-large vacancy open right now. And if you can encourage tribal leaders, we've had some pretty good success in the last couple of years with advising NIH on how to move forward with respect to their engagement in the Indian community. And so we want to keep that ball moving, and I'd like to recruit. So if you know of tribal leaders that have an interest, they don't have to be signed. We have people on our group that are not PhDs, but people who are practitioners that have phenomenal first-hand knowledge. So please help get the word out. So I'll keep the ball rolling. Other comments from the group? And, well, we had one online, but I think we kind of answered it. So it was just to remind us that Canada, Brazil, Mexico, India, China still allow gene patenting, if I'm saying it right. How is this data going to be protected internationally? Does that make sense?
Yes, and I think it's the same way it's protected domestically. The data can't leave the enclave, and so it will not be sold or distributed to anybody outside of the enclave, and so I think that's the answer. I know people are concerned about piracy, literally piracy, information piracy. But none of the data can be downloaded. So.
I just don't want the Russians to have access to my data. I don't know why they would want it, but they perhaps already do, yeah. Okay, other comments? We don't have to go to the whole time if it's not necessary. So then I will hand it over to Dave, because Dave's going to do some summary comments for us, if I have that right. Yeah. It says it right here. Whereas Dr. Tabak is doing that.
I'm happy to defer to Dave since we learned what a great job you're doing. So go ahead.
Oh, you were in doubt. Oh, you were in doubt. Really? I wrote down to, actually, when I outbid you, I want to double his budget. I propose that we double his budget.
Well, I'll just say a couple of things. Really, just to thank everybody. This has been an extraordinarily rich session. I learned a lot. I really did, and so I really thank you personally. We are in this for the long haul, and so please do submit additional comments as you are able to formulate them, and stay tuned, to watch as this unfolds. But on behalf of NIH and the All of Us program in particular, thank you all for being here. But Dave, if you'd like to have the last word.
Great. Thank you, Dr. Tabak. I did want to say that I think that one of the challenging components of the All of Us research program is that they are taking on a lot of topics that are far in advance of what the Thoreau office has been able to address. We are beginning to address the very difficult questions around biosamples, around data sharing and data management in coordination with our Office of Science Policy. But the All of Us research program has identified this need, and they are moving ahead, and I think that's what the challenging part about it is, and we're trying to catch up. And I think that there are going to be some things that we don't capture, but as Dr. Tabak said, this is going to go through continual refinement. So even though we may get tribal nations early on that want to be a part of this, there will be modifications and changes that can happen as we move forward, as we continue to learn and grow. One of the things I want to make clear is that through the work of the Tribal Health Research Office, what we do is that we don't let progress suffer from the evils of perfection. We want to make sure that we continue to move forward. And it may not be perfect, but we're making progress. And with all of your help, we really appreciate this. Some of the things that are going to be long-lasting that we've heard time and time again are workforce development and capacity. Those are big things that are going to take time. We've begun to engage the text, and we're going to continue to do that. But we're also trying to educate the scientific community about how to culturally and respectfully engage and ethically engage our tribal communities. So there's a lot happening within Thoreau. We really appreciate partners like Abigail for providing very clear comments and recommendations on how we do this. And others in here, we really thank you for your participation, and our members of our Tribal Advisory Committee. Michael's here as a representative, and Chairperson Payment. And this is, again, we're increasing our engagement with the tribal communities to address one of the 4 priorities within the Tribal Health Research Office. Actually, it's the first Trans-NIH strategic plan for tribal health. And you'll be seeing a lot more information coming out about all the work the agency is doing to address the specific needs in our tribal communities. So thank you for coming, and we look forward to receiving your comments. One of the things that the All of Us program may do, I'm not sure if they're going to do this or not, but it's standard practice for the Tribal Health Research Office is to submit an RFI so that people who are not in attendance can submit comments through another mechanism. We usually do our RFIs or post our RFIs after the final consultation so that we've seen that the comments from tribal leaders, it's a much more honed and refined response because they've been able to see all the additional comments leading up to that final RFI. So usually the comments that we get back on that final RFI are very concise and very specific to the ask of what's at hand. So again, thank you all, and then I'll be wandering around here for the rest of the meeting, so look forward to talking to you about all of our great work.
Back. Earlier I said that sometimes things get lost in the translation. As tribal leaders, you have to learn to advocate. Sometimes you speak different languages. It could be Ojibwe, it could be English, it could be geek. I said that earlier. Geek. It could be Klingon. But keep advocating for your people. Miigwech. An evaluation for gender collective.